Welcome, everyone. Thank you for joining us for our presentation titled, How Do We Bring Lung Cancer Diagnostic Biomarkers to the Clinic? It's my pleasure to introduce you to Dr. Pierre Massion, Assistant Professor of Medicine, Department of Medicine, Vanderbilt University School of Medicine, Nashville, Tennessee. Dr. Massion attends a pulmonary and critical care inpatient service and the pulmonary outpatient clinic at the Nashville VA Medical Center. His research interests include genetic and proteomic strategies for the early detection of lung cancer, chemopreventative strategies for the primary and reoccurrence of lung cancer, and investigation of the role of genomic abnormalities in lung cancer. For a complete biography on our speaker, please visit the Biography tab at the top of your screen. Now, if any questions arise during the presentation, we encourage you to submit them in the Q&A box. Our speaker will address your questions following this presentation. Please join me in welcoming Dr. Pierre Massion. I will now turn the presentation over to him.
Well, thank you very much for this introduction, and hello everybody. It's my pleasure to be here today to discuss with you how we bring lung cancer diagnostic biomarkers to the clinic. As a disclosure, the message to remember is that I work with many industries. I typically don't get funding from them, and therefore I remain independent from the industries in general. But the work that I'm going to be presenting is funded by the National Cancer Institute, the Department of Defense, and the Veterans Administration. So lung cancer is a big problem, as you all know. You probably all know somebody who have suffered from that disease, who may have died from it, who are currently struggling with it. It's a very important killer. It's the #1 cancer killer in the US and in the world. And if you look at all diseases that are leading to a death, the respiratory death corresponds to about 50% of all deaths. Among those, lung cancer is the biggest culprit. 38% of all people dying of respiratory diseases are dying of lung cancer. So when you think about the natural history of lung cancer, it's not perfectly known, but what we know is people eventually develop a risk over a long period of time. They may start smoking at the age of 10 or 15, get on with their lives, and most of them are diagnosed at around the age of 70. At that time, only 25% will benefit from a cure. So our job is to try to diagnose the disease early. Why are we interested in that is because when you diagnose it early, you have a better chance of surviving. It's true for most diseases, it's just common sense. Detect the nodule early on and you should be able to operate on it and offer a patient a cure earlier than at the typical time of diagnosis when only 25% of them will survive. If we diagnose it very early on, 80 or 85% of them could survive the disease. So there's a great impetus to develop strategies for early detection. So why is it important, particularly important in Tennessee, is because we are suffering from an endemic area of lung cancer. You see on this map, whatever is brown and dark brown corresponds to the center of this endemic area. The percentage, and actually the prevalence of lung cancer in this southeast part of the country is about 40% higher than in the rest of the country. And it maps pretty well with the intensity of smoking, which makes sense because smoking is the #1 cause of cancer-related mortality. So we have to do something about this disease. And if you don't know about it yet, there is a screening strategy for early detection of lung cancer. And this is lung cancer CT screening. There are two studies represented on this slide. On the left-hand side, the results from the National Lung Screening Trial that demonstrates that not only the number of cancers that we diagnose in the lung cancer screening are greater, but more importantly, the death rate associated with lung cancer screening is lower, meaning that we are saving lives. In fact, we save 20% decrease in relative death from lung cancer with low-dose chest CT. And these results were very much mirrored by another study done in Europe, in the Netherlands and in Belgium, where they found that the lung cancer incidence was also increasing with screening, but that the death rate was lower. Actually, their death rate from lung cancer with the lung cancer screening strategy was even better than what we found in the US. They didn't find a 20% relative decrease in mortality, but up to 35%. So that brought the entire world to be excited about lung cancer screening and try to implement this strategy. One of the biggest problems is that this strategy is still at its beginning. You would expect that high-risk individual would undergo lung cancer screening, but about only 10% of them are following that strategy at the moment. It took very long time for mammography to be uptaken by most women, or colonoscopy to be successful. And we hope that we can and accelerate the implementation of lung cancer screening because it saves lives. If I show you this chest CT, you recognize the right lung here, the left lung on the right-hand side, and you see a nodule on the right upper lobe. That nodule is dense, spiculated, about 1.5 to 2 centimeter diameter. It's a lung cancer. That's an estimate. It's a guess. It's a probability that this is likely to be a lung cancer. And I can tell you that because I see that there's a culprit on the chest CT. The culprit is outside the chest. You see here, there's a lighter in this patient pocket and a pack of cigarettes. So now we're linking causes and diseases, but this is anecdotal. But this slide is to tell you that lung cancer detection can be complicated. And I told you that it's related to the fact that chest CT alone does not always give you the answer. And here's why. Because not only lung cancer is very prevalent in the Southeast, but it's also true that this region of the country is also the area where the highest concentration of histoplasmosis is encountered. And this fungal disease, as an infectious disease, can look and appear on chest CT just like this one. So it's a big confounder. It's a big struggle in the Southeast region of the United States. So now we think, okay, we can use chest CT, and is it the panacea for lung cancer screening? And we're going to save most lives. I told you we don't save everybody's life with low-dose chest CT. This slide gives you a little idea of what proportion we are really saving. If you're thinking about all people dying of lung cancer in 2020, we have about 160,000 dying of this disease. If you were to screen according to the National Lung Screening Trial criteria for screening, meaning that you're 55 years of age and less than 75, and if you have smoked for 30 years, at least a pack a day, and you haven't quit more than 15 years ago, we could eventually save 42,700 lives out of these 160,000. But in fact, we are not as good as that, because if we had to implement lung cancer screening in that population, we could save up to 12,000 lives. And 12,000 lives is only about 8% of the entire population dying of lung cancer. So we have a long way to go, but now we have at least a strategy for early detection of lung cancer. And yet we have to go a lot better than just lung cancer screening with the current guidelines. There's a big effort currently to actually expand the population we may screen, and we hope to save many more lives this way. So what is the problem? The problem is when you screen for lung cancer, and I want to come up with a strategy to detect these nodules. We have it by chest CT. This is a nodule that looks very suspicious. Now, not all lung nodules are cancerous. And we want to find a biomarker strategy or some type of imaging strategy to tell us in a non-invasive way which of these nodules is going to be malignant. Nodules is a big problem. You see there's 1.6 million nodules in the United States diagnosed every year. Very small number are going to be cancers, and yet many of them undergo surgery. The nodules that we worried about are those that are 6 to 30 millimeter in diameter, that are non-calcified, and we can bring them into different risk groups. If you have a tiny nodule that's really smooth, it's going to be low risk, less than 5%. If you have a big nodule like this one, spiculated, dense, and showing characteristics of high risk, your probability of cancer is very high. The difficult zone is the intermediate zone, and that's the area that we are trying to improve our diagnostic in a non-invasive way. We hope that detailed imaging can help us with this, and we hope that eventually biomarkers will come to the rescue. So this lung cancer nodule is a big problem. It's $28 billion a year, and it's about the same cost of what osteoporosis management and treatment represents in the US. So it's a big healthcare burden. So how do we eventually make progress? Well, we have big problems because nodules are not all the same. You see this small nodule in the left lower lobe here was present in 2005, and this nodule remained stable over 6 years and never changed. This is most likely a lung cancer, but a rather indolent cancer. Now, some of these cancers are not so indolent. And if you look at this slide here, this nodule diagnosed in 2005 started growing slowly over time. And finally, in 2013, the patient had a PET scan done. He was active, very hot on PET, and the patient underwent a resection of that left upper lobe, and what was found is a tumor, an adenocarcinoma. Well, the same patient actually, over time, started developing another nodule. You can't even see nothing here, but look at here. There's something coming up. Over time, this nodule was growing. The question was, is it the same disease or a different disease, the same cells that went to a different lobe of the lung? It happened to be a different tumor on the same patient, also a lung adenocarcinoma. So the message here is that although lung nodules come in different forms, some can remain indolent and some can become aggressive, and it's difficult to identify them. The last nodule that I showed you that was a cancer was not PET active. So imaging is not the answer to everything. So what's the biggest challenge? The challenge is that we have a large portion of people with intermediate risk for lung cancer. The nodule, we don't really know what to do with. And we want to reduce that group because this is the group where we make most of the mistakes. And what we are proposing here is that we basically bring some type of biomarker to the rescue. We're gonna test all these individuals in yellow and ask whether a biomarker can change their group classes. Maybe a portion of these people can become green, meaning safe to follow over time. We rule out cancer in that group. And the converse may be true. Some proportion of these people may be higher risk, and we bring them in and we offer a biopsy because they're more likely to be malignant. So these reclassification of the intermediate group from the yellow to a low-risk group in green or a high-risk group in red is the goal of this effort. We are trying to deal with these tough nodules. So would eventually a biomarker help us here is the question. And we can talk briefly about biomarkers and what they need to show. Well, biomarkers are basically a reflection of whether what we're dealing with may be either cancer or no cancer. Well, we have to make sure that we have an assay that's accurate and that's valid, that it has been tested in other population, that it causes a large number of cancer to be diagnosed early. And if you diagnose it earlier, instead of diagnosing most people stage 3 or 4, you shift it to diagnosing stage 1, where the prognosis is a lot better. You can survive, and up to 70 or 80% of people with stage 1 lung cancer now survive 5 years. Now, we want to reduce the number of false positives, and we want to make sure that whatever biomarker brings in eventually makes a big difference in terms of it adds value to what the current standard of managements are. The strategy, the biomarker that is an imaging or a blood biomarker must be cost effective and eventually save lives. That's the ultimate goal. But I think that a reasonable target is to demonstrate that we are adding value to the current management. This is where we want biomarkers to be. So in collaboration with a group in the United Kingdom, we started looking at imaging biomarkers. And what we did is we grabbed a large number of chest CTs, like the one I showed you earlier. We had a total of 15,000 benign lung nodules from different individuals and about 932 cancer. And that population comes from the National Lung Screening Trial. So we identified so many nodules. And from all these images, we developed an artificial intelligence strategy to identify what is cancer from what is benign. And then we decided that once we have our artificial intelligence model, we're going to validate it. We're going to validate it in 3 different ways. One, within the same trial, the National Lung Screening Trial, and then in 2 independent cohorts, one from the US and one from the UK. And here is what we found. We grouped that population. We had to deal with a large population from the National Lung Screening Trial, over 15,000 nodules. Vanderbilt, we had 116, and in Oxford, 463. And then we tested our artificial intelligence model here in the NLST and validated in these different groups. There are different characteristics. There's too many numbers on this slide, ignore it. But this is to tell you that we basically trained in 1 cohort and validated in 2 independent cohorts. So how does this artificial intelligence model works? It's a prediction and machine learning method. We call it lung cancer predictor convolutional neural network. The neural network is basically taking a bunch of images like you see in the A part of the slide and bringing them to a computer to have them recognize what is a cancer and what is a benign nodule. And then we train the classifier to, at the end, gives us an answer as to whether the image we have in front of us is likely to be cancerous or not, and give us a percentage of likelihood score of cancer. Let's say 75 chance that this is a cancer. This is how we train it. In B, you see that in the training data set, we provide the artificial intelligence model with 3 nodules, 2 that are benign, 1 that's malignant, and then we give them a large number of nodules. And the better the model, the model gets a lot better with the large number of nodules. So we end up with over 15,000 nodules and train the model. If the model gets the answer wrong, we retrain the model, we refine the model. There's an iterative aspect to this training procedure. And at the end, we give the model unknown nodules and we ask them, tell us what it is. And then we see in what percentage of the time we are accurate at determining that this is a cancer and this is a benign one. So here, I wanted to show you a little video that illustrates how we eventually perform this analysis. Based on the images that are selected on our imaging record, we can actually download directly the images, and you'll see that we screen through the images really quickly. There is a nodule in the right upper lobe. We're going to identify and select that nodule in the right upper lobe, find its center, click on the very center of the nodule itself, and try to draw a sphere around it. Now the nodule is going to be segmented, and we're going to ask the software to give us a probability of cancer. And here we are. The probability of cancer in this particular nodule is 98%, very high risk for cancer. Now, we did this in the National Lung Screening Trial data set, and what we showed is that compared to a clinical model as to whether this is malignant or not, the artificial intelligence tool gives us better discrimination. These are called receiver operative characteristic curves. And you see that the pink curve is better because it's more to the left and to the top part of the slide. And it gives an accuracy that goes from 85% to 92%. These 7% improvement in accuracy don't seem like a large number, but it's a tremendous improvement. Now, if we try to validate this in the Vanderbilt cohort or in the Oxford cohort, every time we beat the clinical prediction alone. And the clinical prediction really include the age, the history of smoking, the history of cancer in the past, how big the nodule is, and whether his shape is irregular or irregular. So our artificial intelligence model is quite better. And actually, it allows us to reclassify about a third of the nodules. Back to this figure here. If you see these intermediate risk nodule in yellow, we were able to reclassify about a third of them into a lower risk group, a high risk group. What does that do? Well, it actually decreases the number of not necessary procedures, so unnecessary procedures we do. And it also decreases the time to diagnosis because we're better and faster identifying the bad guys when we rule in disease. So this is the state of the art now of this biomarker, which is an imaging biomarker. So where do we want to go there? We have demonstrated that we have discovered a good model. We have validated analytically and in 3 different cohorts. Now we want to do a clinical utility study. And that clinical utility study will tell you and me whether this is going to help patients get their diagnosis done earlier and with fewer procedures, and whether eventually this may save lives. So we need to get to a proposal of a clinical trial and to bring patients and biomarkers onto a train. And the idea that we are riding this train with our lung nodules, and we want some biomarkers to be tested to see whether we are accurate and clinically useful. We're going to test a bunch of biomarkers on the train. We're going to take some on it, and we're going to let some of these biomarkers that are not useful leave the train. And we'll arrive at destination, hopefully with a great proposal. So how do we propose to do this? In a randomized fashion. What does it mean? If you are, let's say, 60 years old, and you present with a lung nodule that's in this intermediate risk, we're not totally sure whether it's benign or not. We would randomize you into 2 groups. A group that has just the standard of care, and we follow you over time. That's our control group. Or an intervention group. And the intervention group here will offer some type of biomarker. It could be a clinical model, a blood biomarker, or our imaging biomarker. And our imaging biomarker will be applied directly to the chest CT that you have, that you come to your doctor with. We look at the imaging, we run our artificial intelligence tool, and the tool tells us that, no, in fact, you're not in the intermediate risk, you are much lower risk, you're in the low risk group, and we can follow you safely with just a chest CT. That would be quite reassuring. If the biomarker, our imaging lung artificial intelligence model tells us, no, your nodule is actually pretty high risk, we'd rather you get a biopsy. We'll follow these strategies, get the biopsy that your doctors decide on getting, and eventually look at the endpoint. And in this trial, within 2 years, we'll know whether we're able to improve the diagnostic accuracy, decrease the time it took us to get the diagnosis, and reduce the number of invasive procedures. So this is the goal of where we want to take these candidate biomarkers. Now, The biomarkers can be found in the blood, like a protein or DNA testing or a genomic test in the circulation of your blood. And we can test these biomarkers following the same clinical trial strategy here and reclassify your risk based on the results of the biomarker into low or high risk group. And then we will be able to test the difference between our intervention strategy versus the control strategy. Well, with this, I want to finish by telling you that ultimately we want biomarkers into the clinical arena. They need to be non-invasive. We need to demonstrate that we improve the management by showing few morbidity and decreasing the number of expensive procedures. We want to improve the decision making. We watch and wait or we biopsy. And we want to make sure that we have the right population that we're focusing on. And we want to test a technology that at the same time is quite sensitive and that is specific as well. It tells us that this nodule is a cancer. We better not make a mistake and take you to surgery for the wrong reason. To answer these questions of clinical utility, we need a clinical trial. And this is what I'm currently working on with a number of collaborators. So with this, I want to conclude. And I think I told you that the biomarkers have different layers of evidence. In my opinion, those that are valuable are better than the standard of care, which I showed you with this artificial intelligence tool. The diagnostic biomarkers should not have harm, and it should be offered to patients in a shared decision-making. We need to discuss the accuracy and the performance of the biomarkers and accept some uncertainty of any new biomarker that we bring into a clinical study. Patients must be willing to participate into this. And I think when we want to scale up this type of testing, we want to partner with the industry because they are very good at eventually bringing some of these candidate biomarkers to the clinical bedside and have those eventually approved by the FDA. So with this, I want to tell you that we need randomized clinical trials also in the diagnostic setting. We want to work with people with clinical expertise, and we want to make sure that the patients are involved in the design of these studies and that we're honoring their wishes. So in my final slide here is to say that we talked about how do we personalize the risk. We need an informed consent. We want to keep it simple. We want to work with statistical models that are very necessary to help us assess the strength and robustness of our biomarkers. We need to look at the continuous risk factors and risk prediction models to eventually find a solution to address the shortcomings of our current evaluation of lung nodules. I want to thank all the patients who are participating in the studies that I've presented here, and a large number of collaborators without which I could not do this work. And these involve people who are research coordinators, biostatisticians, clinicians, imagers, of course, people expert in biomarkers, biorepository, chemistry, epidemiology, and screening in general. So I want to thank the funding support and my collaborators and you all for listening to me today. And hopefully I have provided you with some good hopes that not only lung cancer is a big cancer mortality problem, but we are trying to tackle it with new early detection methods. And in these detection methods, chest CT screening seems to be remarkably efficient. We want to keep improving its efficacy by bringing biomarkers to non-invasively diagnose the disease early and bring it to a treatment. So with this, I want to thank everybody and wish you a very good day. I'd be happy to take any question at this point, and back to you, Kristen.
Thank you, Pierre, for that outstanding presentation. We will now move into the live Q&A portion of our webinar. Now, as a reminder to our audience, please submit your questions via the Q&A box. Okay, Pierre, our first question. Is there any strategy for early detection among smokers?
So among smokers, the best strategy is to convince them to quit smoking. That sounds a little facetious, but it's the truth, and it should be the priority number 1, 2, and 3. Once the people are high risk, meaning that they're over the age of 55, they've smoked for about 30 years, a pack a day or so, and then they quit less than 15 years, they should undergo lung cancer chest CT screening. And this is not a one-time test. This is a process, a surveillance program over time, over long periods of time, until there's no need for screening anymore. So yes, there is a strategy for smokers. Now, for non-smokers, that's a different problem. We currently do not have a good strategy for early detection of lung cancer among non-smokers. And those people represent about 10–15% of the population. It's a larger population in Southeast Asia, where up to 30% of the people diagnosed with lung cancer are never smokers. It's a very important problem to tackle, and we need to do a lot more research in that space.
Thank you. Now, what's the biggest challenge in developing biomarkers for lung cancer?
The biggest challenge to develop biomarkers, in my opinion, is designing the studies early on right and choosing the population that you want to bring your biomarker in judiciously. Let me give you an example. If you want to find a biomarker for early detection of lung cancer, I would not start looking for biomarkers in people with very advanced stage disease who don't undergo screening. I would try to design studies to find the biomarker in the population that you intend to screen. That's very important. The second is that you need to have a very sensitive method, because chest CT screening is actually pretty sensitive to find nodules. But when we find nodules, we know that the disease has been there for months. So ultimately, you want to be exquisitely sensitive and find the disease very early. But the problem when you're very sensitive is that you may find some false positive. You may be mistakenly taking a nodule for a cancer when in fact it's a small infection. So that brings me to specificity, which means that when the disease, when the nodule is called a cancer, it must be a cancer, okay? So, and that if I call it negative, it's not a cancer. I better be for sure that this is not a cancer. So this specificity is very important. These two metrics are very important. And another important part is to bring the biomarkers to clinical utility, meaning that it's not good enough to have a good marker that discriminates one from the other. It has to be better than the standard of care. And most biomarkers fail at that level because to beat standard of care is hard. It's like athletes. When you get good in athletics, you know, you could be a wonderful basketball player, but to make the State Warriors team, you need to be at the very best. And few are elected in that zone. So that's where we want to be.
Thank you for that answer. And what does clinical utility mean?
Well, clinical utility means something different from different people in general. But if I ask you what it means, you probably would tell me, well, something that'd be good for me. And that's the right answer. In medicine and in biomarkers research, clinical utility has different layers. One could think that if I manage to diagnose a lung cancer at an earlier stage, it may be clinically useful. But if that biomarker gets me an earlier stage without being better from what we're already doing, it's not good enough. So here the benchmark is not big enough. What's the next benchmark? The benchmark would say, okay, it's better than standard of care. Well, that would be terrific. Already people start commercializing the biomarker, but it may not be good enough because it may not demonstrate that we're actually saving lives. Ultimately, we want to save lives. Well, people say, well, maybe that's too high of a bar. And you may want to lower the bar a little bit and say, well, at least if we're saving money in managing lung nodules, you would reach a reasonable clinical utility benchmark. And so it depends on who you're talking to. It's a very difficult concept. Clinical utility has many different layers and many different meaning to different people. But to most patients, it's pretty simple. It's whether this is going to help me in managing the disease better than everything else that's out there at the moment.
And Pierre, we have time for one more question. I'd like to go with this last one. Where would you think biomarkers fall in the future in comparison to imaging?
Well, I'm pretty sure that biomarkers have a role. Now, the technologies are getting better and better. We're getting more sensitive at detecting very subtle differences between groups. We are getting very good at detecting minute traces of abnormal molecules in our blood. It's true for proteins, it's true for transcripts, RNA, it's true for DNA, it's true for methylated DNA or marks on the DNA. It's true for metabolites that we can detect in the blood. I think the technology keeps improving and will bring very early witness of that disease that's circulating somewhere. Now, the challenge that the biomarkers, again, need to add complementary information to what we already know. And in many diseases, we see that biomarkers are growing in their importance. You see this in cardiovascular medicine, in diabetes management, in the management of autoimmune diseases. You see this in the management of many diseases. Biomarkers are coming to the forefront because they're molecular and they are beyond the macroscope. They're beyond what traditional medicine can do. Yet they have a tough mark, and it's to show added value to the current standards. And this is the biggest challenge we have in biomarkers research. I have no doubt that some type of non-invasive biomarkers is going to help us diagnose lung cancer in a non-invasive way, and will add value to imaging. And by the way, imaging is improving every day too. So we have better resolution scanners, multiple detectors, very small voxel density. We're going to get artificial intelligence models better than the one I showed you. And we're going to be not just looking at the nodule, we're going to look at the entire patient. And maybe it is that the emphysema that's associated with the nodule that's going to give us even more information. So we have a lot more study to be done in the biomarkers field, biomarkers that are either molecular-based or imaging-based. So there's a lot of hope for the future. And the future is coming very quickly. It's soon that we'll see these differences.
That it is, Dr. Massion. And thank you so much for this excellent presentation and very detailed Q&A session. I also want to thank our audience for their outstanding questions. We hope that you have found today's presentation to be informative and insightful. Today's presentation will be available for on-demand viewing. Also, don't miss out on the other valuable presentations on our agenda. Just visit that agenda tab in the auditorium for a full listing. Thank you again for your participation. And Dr. Massion, thank you again for your time. Until next time, everyone, have a great day. Bye-bye.
Bye-bye. It was my pleasure. Thank you.
Thank you.